Hello, everyone, and welcome. Today, we're diving deep into what is truly one of the Mount Everests of our specialty, the anesthetic management for a simultaneous liver and kidney transplant. These are the cases that test every bit of our physiological knowledge and our ability to react in real time. We're talking about patients at the absolute edge with dual end-stage organ failure. And honestly, the success of this monumental surgery rests squarely on our shoulders in the OR.
All right, so here's how we're going to break it down. We're going to start where it matters most, with real patients, looking at some challenging clinical cases. Then we'll peel back the layers and really get into the nitty-gritty of the pathophysiology. After that, we'll build out our intraoperative playbook, step by step. And of course, we have to look at the data. What do the outcomes tell us? Finally, we'll wrap it all up and distill everything into the core principles you can take with you to your next case.
You can read textbooks all day, but to really grasp the complexity here, we have to start in the real world. So let's walk through a case together. This one is a fantastic example that really shines a light on all the critical decision points we as anesthesiologists have to navigate. Okay, so take a look at these scans. Our first case is a patient with autosomal dominant polycystic kidney disease, or ADPKD. And wow, just look at the sheer scale of this. On the left, you see kidneys that are just massively distorted by cysts, which is what's causing the end-stage renal disease. But then look to the right. The liver is almost completely replaced by these enormous cysts as well. So right off the bat, you're not just thinking about organ failure, you're thinking about the immense physical, structural challenge this presents for the surgeons and for us.
Now this is where it gets really interesting. Let's look at the numbers. You see this fascinating clinical puzzle? Her liver synthetic function, it's actually pretty good. Total bilirubin is normal at 0.4, and her INR is 1.06, which means her coagulation is intact. So why the high MELD score of 20? Well, it's being driven almost entirely by her creatinine because of the end-stage renal disease. But, and this is a big but, look at her Child-Pugh score. She's a class B, not because of encephalopathy or poor synthesis, but because of severe ascites. That ascites is our big clue. It's screaming portal hypertension, even with preserved synthetic function. Understanding this specific mismatch is absolutely critical for forming our anesthetic plan.
So this brings us to the pivotal moment in the OR, the big management decision. We decided to proceed without putting the patient on intraoperative CRRT. Now you might ask, why would we do that for a patient with end-stage renal disease? It comes back to that last slide. Because her liver was metabolically competent, we made a calculated bet. We anticipated that the new liver graft, once reperfused, would be able to handle the inevitable metabolic storm, the acidosis and hyperkalemia that comes with reperfusion. And it paid off. You can see she did have a significant acidosis, with the base excess dropping to minus 12.4. But it was transient. Her new liver kicked in, started metabolizing that lactate, and she began to correct on her own. It was a beautiful validation of understanding the specific pathophysiology, not just the diagnosis.
That case is the perfect springboard to go a little deeper into the why behind all this. Because to anticipate these problems, you have to have a rock-solid understanding of the pathophysiology. We need to know the enemy, whether it's the hemodynamic chaos of hepatorenal syndrome or the structural challenge of ADPKD.
So first up, hepatorenal syndrome. Let's get our definition straight, because the wording here is everything. HRS is a functional renal failure. I want to repeat that. Functional. If you were to biopsy these kidneys, they would look perfectly normal. The problem isn't the hardware of the kidney itself. The pathology is a result of the extreme hemodynamic derangements being caused by that failing liver.
And this diagram lays it all out beautifully. It all starts with portal hypertension. This leads to this massive, uncontrolled vasodilation in the splanchnic circulation, basically all the blood vessels in the gut. All that blood pools there, and even though the patient's total blood volume might be normal or even high, their effective arterial blood volume, what the rest of the body sees, just plummets. The body panics. It thinks it's bleeding out, so it slams on the gas, activating the renin-angiotensin system and the sympathetic nervous system, clamping down arteries everywhere else to try and maintain pressure. And which organ is the first victim of that intense vasoconstriction? The kidneys. They get starved of blood flow and they begin to fail.
Now, how we talk about HRS has changed, and for good reason. We've moved away from the old, somewhat blunt Type 1 and Type 2 classifications. The new framework is much more nuanced and aligns with the standard AKI guidelines we all know. We now talk about HRS-AKI, HRS acute kidney disease, and HRS chronic kidney disease. And this isn't just academic shuffling. This change is clinically vital because it helps us better prognosticate. It gives us a better sense of whether that renal failure might be reversible, which is the million-dollar question when deciding if a patient needs just a liver or both a liver and a kidney.
But then you have a totally different beast, like ADPKD. Here, the pathophysiology isn't primarily hemodynamic, it's mechanical. It's a problem of sheer size and space. Those liver cysts create an incredible mass effect. We're talking about intractable pain, patients who feel full after 2 bites of food leading to malnutrition and compression of surrounding structures. And from a surgical standpoint, it can be a nightmare. Imagine trying to operate when the organs are so massive they fill the entire abdomen. So in these cases, the indication for the combined transplant is clear. You have end-stage renal disease coupled with these debilitating symptoms from the polycystic liver.
Okay, so with that solid foundation in pathophysiology, let's pivot from the why to the how. It's time to build our intraoperative playbook. What are the core strategies we need to employ to get these incredibly sick patients safely through this procedure?
First things first, monitoring. This is a situation where more is more. You need to build a complete, real-time, 360-degree view of the patient's physiology. We're talking dual arterial lines, one radial, one femoral, because things can go wrong. A PA catheter is essential for tracking cardiac output, filling pressures, and vascular resistance. TEE becomes our eye on the heart, giving us direct visualization of volume status and contractility. And of course, you absolutely need real-time coagulation monitoring with ROTEM or TEG to guide blood product administration. This isn't a time for minimalism. It's about having every piece of data you need to navigate the inevitable instability.
Now let's talk drugs. Every choice we make has to be deliberate. The theme here is predictability. In a patient with 0 liver and kidney function, you want drugs that don't rely on those organs for clearance. This is why remifentanil is such a fantastic choice. Its metabolism is organ-independent. Same for neuromuscular blockers. We reach for cis-atracureum because its Hoffman elimination in the plasma means its duration of action is predictable regardless of organ function. By making these smart choices, we eliminate huge variables from an already incredibly complex equation.
In this table, this right here is the heart of the challenge. This is the central conflict of SLKT anesthesia. Look at the first phase, dissection. Our goal is to minimize bleeding from that congested liver, so we run the patient dry. We keep the CVP low, maybe 5 to 10. But then, fast forward to kidney reperfusion. Now our goal is the complete opposite. We need to ensure that new kidney gets enough blood flow to wake up, so we have to pivot 180 degrees and aggressively volume load the patient to get that CVP above 10. Being able to skillfully manage this planned, dramatic swing in hemodynamics, that is the true art of this anesthetic.
This delicate balancing act, this tightrope we walk, naturally brings us to one of the most important questions we have to answer in the OR. When do we pull the trigger and initiate intraoperative CRRT?
The decision to start CRRT isn't just about the diagnosis of ESRD. It's a dynamic tool we use to manage acute instability. We'll start it for pre-existing life-threatening hyperkalemia or a profound metabolic acidosis. We'll also use it if we anticipate that the patient's native liver is so sick it simply won't be able to handle the metabolic insults of the surgery and reperfusion. Think of it as our external metabolic support system, a safety net that gives us precise control over electrolytes, acid-base status, and volume when the patient's own systems are offline.
So we have our playbook, we understand the pathophysiology, we know the moves, but what about the results? Does all this effort actually lead to good outcomes for our patients? Let's take a hard look at what the evidence says.
This Kaplan-Meier curve is, frankly, pretty remarkable. It's comparing long-term survival for patients who got a combined liver-kidney transplant, that's the green line, versus those who got a liver transplant alone, shown in blue. And what's immediately striking, and maybe a little surprising, is that those lines are practically sitting on top of each other. The long-term survival is incredibly similar. And here are the numbers to back that up. At 5 years after transplant, the patient survival rate is 74% for the combined procedure versus 75% for liver transplant alone. That is incredibly powerful data. It tells us that for the carefully selected patient, adding a kidney transplant to a liver transplant does not compromise their long-term survival. It is an effective and durable therapy. But, and there's always a but, that fantastic long-term survival doesn't mean the immediate postoperative road is easy. The journey to get there can be tougher. Look at this table. While many complication rates are similar, the need for postoperative dialysis is dramatically different. 31% of SLKT patients still needed dialysis temporarily post-op, compared to just 3% of the liver alone group. This tells us that delayed graft function in the new kidney is a real issue, and the early post-op period is often more resource-intensive and complicated for these patients.
This higher risk of complications and the difficulty in predicting who will recover kidney function brings us to a major policy discussion, the safety net.
This is a crucial organ allocation policy that essentially says if we do a liver transplant alone on a patient with renal dysfunction and their kidneys don't recover, they get high priority status to come back for a kidney transplant later. It's an attempt to avoid doing an unnecessary kidney transplant up front, and it's a huge factor in the preoperative decision-making for these borderline cases.
All right, we've covered a lot of ground, from individual cases to deep physiology to population-level data. So let's bring it all home. Let's synthesize everything we've talked about into a few core practical principles that we can all apply in our clinical practice.
So here it is boiled down. First, SLKT works. For the right patient, it offers excellent long-term survival. Second, our biggest job in the OR is to be masters of hemodynamics, actively managing those conflicting goals for the two different organs. Third, be smart with your pharmacology. Choose drugs with predictable organ-independent metabolism to reduce uncertainty. Fourth, remember that CRRT is a tool for managing acute instability, not just a default for every ESRD patient. And finally, never forget that the patient's preoperative liver function, not just their diagnosis, is probably the single best predictor of how stable or unstable they will be during the case.
And I'll leave you with this final thought to take with you. The next time you're faced with one of these borderline patients, the one with advanced cirrhosis and a nasty acute on-chronic kidney injury, how does all this evidence shape your thinking? How do you, as the anesthesiologist, weigh the immediate, known risks of a massive SLKT against the uncertain hope of renal recovery offered by the safety net? This isn't just a surgical question. It's a profound clinical judgment call that lies right at the heart of what we do.